In this session, I will discuss about a RCA CTO with impenetrable proximal cap and distal cap. History of this patient is 69-year-old male with CT coronary angiogram done in 2012, that is 7 years back, showing total occlusion of RCA. Now came with exertional angina equivalent, more in postprandial state, with a normal sinus rhythm, good LVRV function. And there is no RWMA in RCA territory, saying completely viable territory. He is non-hypertensive, non-diabetic, underwent radiotherapy and chemotherapy for CAF left vocal cord in 2007, but no subsequent recurrence. This is a CT angiogram done in 2012 showing a chronic total occlusion of RCA with the calcium sitting close to proximal cap as well as in the middle and close to distal cap. And we can see this is the proximal calcium, which is almost full moon calcium, that is circumferential calcium sitting in close to proximal cap. And there is also a bifurcation at the distal cap. And this is a coronary angiogram done now, so which shows LCX is not coming, it's only LAD, so and which is showing intermediate lesion or 40 to 50% lesion in proximal LAD, and RCA is filling from LAD. And this is an RCA showing total occlusion with a very short stump, proximal stump, and a CTO with a significant length of CTO, and LCX is coming from right sinus, almost close to the ostium of the RCA. This is our RAO view showing a CTO long segment without any stump and with a branched bifurcation at distal cap. And this is a RAO view of LAD to show the septal collaterals. There are good septal collateral. This is the first septal collateral and this third septal collateral. So, but the first one is almost like brook shaped, and third septal collateral is good, but with the corkscrew bends in the middle. So coming to the analysis of JCTO score of this CTO, so it's an ambiguous proximal cap, length is almost 40 millimeter, and there is calcium sitting in proximal CTO, mid part of the CTO as well as at the distal cap, and the distal target is very good, and there is a bifurcation at the distal cap. There is a good branch, significant RV branch coming out of just after distal cap. And there is an epicardial coronary collateral here from atrial branch to the RV branch, and there is good septal collaterals, almost 2 septal collaterals, but the first one is almost like a brook. So JCTO score of this patient is ambiguous cap and significant calcium in CTO. There is no bend in CTO, and the length is almost 40 millimeters, so it is a JCTO score 3. So definitely going to be a tough case for procedure. So if you understand complete coronary anatomy in one picture, so this is how his anatomy is. This is a CTO, very short proximal segment. This is an anomalous LCX coming out of right sinus here close to right coronary ostium. These are atrial branches, and which is giving collateral to RV branch, epicardial collateral, and this is the calcium sitting in the CTO, almost 3 locations, proximal, mid and distal, and there is a small lesion in RCA, in distal RCA. And there is a lesion in donor vessel, that is LAD, and the first septal is like brook almost, and these are like CC0 collaterals, and this is a CC2 collateral, and this is also a CC2 collateral, and this collateral is well visible in RAO, and this distal third septal collateral is well visible in RAO caudal. So coming to the wiring strategy of this patient, so there is an ambiguous proximal cap and an appropriate interventional collateral, that is septal collateral. Distal target is very good. So in such a case, with an ambiguous proximal cap, so directly we can go ahead with retrograde. But in this case, I wanted to try an antegrade briefly. If there is no progress, so then switch to retrograde immediately. So that was my strategy. And if retrograde also fails, that is wire escalation, then you can go to retrograde re-entry, dissection and re-entry, or then antegrade dissection and re-entry. So the possible issues in this patient is, the most important issue is the calcium, so which is sitting in proximal cap, distal cap, as well as mid RCA, so which may cause failure of our wire escalations, and which may need calcium modification for adequate stent expansions. So I started procedure with an antegrade wire escalation. After dual injection, we took a fine cross microcatheter directly with a Gaia wire, so not used filler because it's very tough CTO by its appearance in angio and CT as well as JCTO score. So, but Gaia 2 couldn't advance. It was just bending into this proximal branch. So then I took a stiff wire, that is Conquest Pro, with the 2 bends, but Conquest Pro literally went out of the axis of vessel, of the axis of the vessel. So it is perforated. It is perforated and gone out of the vessel. So at this stage, I immediately shifted to retrograde approach. So I have chosen first septal collateral because that is sitting proximal to the lesions, and it reduces the possibility of donor vessel ischemia. But as the takeoff of the first septal is very abnormal, so we couldn't enter into first septal, so that's why I went into the third septal. And this is a Corsair 150 in third septal. You can see there is a corkscrew kind of bend here. Up to this we went with a cyan wire, but from here cyan was not progressing, so I shifted to CO03, and which went into the PTA, with which we could cross septal, and then I parked CO03 into PLVB to get enough support for Corsair tracking. So now Corsair is in at the distal cap of the CTO. So now we started retrograde wire escalation directly with Gaia 3 wire, but there was no progress with Gaia 3. Then I switched to Conquest Pro 12. It didn't progress. Then I tried a polymer jacket wire, that is Pilot 150, which progressed a little bit, but stuck at the calcium sitting in the distal cap. So at this juncture, so I failed both in antegrade wire escalation and retrograde wire escalation. And what next? So I have two options, either antegrade dissection re-entry or retrograde dissection and re-entry. So if I look at antegrade dissection re-entry, there is no progression of antegrade wire. So initially, so that may need special techniques to cause progression of antegrade wire into CTO, and circumferential calcium in CTO, which may preclude your plans of ADR with crossbar stingray. Sometimes crossbars can stuck at this calcium, and significant branch at distal cap. So this branch can be compromised when you are using an ADR, and intramural hematoma possibility. So these are the issues with the antegrade dissection reentry, and if you go to retrograde dissection reentry, there is no antegrade preparation in this case as the wire has not progressed into the lesion. Not much space in proximal RCA for reentry, and intramural hematoma possibility with knuckle wire. So in retrograde dissection reentry, so the dissection can be created only with knuckle wire, so it increases possibility of intramural hematoma and possibility of slow flow subsequently in the coronary. So out of the two strategies, we favored antegrade dissection reentry despite the side branch and distal cap, because this appears more practical for this case than a retrograde dissection reentry. So what is the strategy of ADR for this patient? So the first thing is we have to advance wire into CTO. For that we can use base with knuckle wire, balloon assisted subintimal entry with a knuckle wire. So once knuckle wire enters into the CTO, cross all the calcium, proximal and mid calcium with the knuckle, and then we can switch to crossbars and stingray for re-entry before this branch, or after this branch, or you can switch to reverse cart as plaque got modified by knuckle. So this is the strategy. So we started with the base, so we kept a 3 mm balloon over the side branch wire, and we inflated balloon. The microcatheter was on the side of the balloon, and then we took a fielder FC with knuckle, and the fielder XT is just crossed, entered into the CTO, and once entered, microcatheter is advanced and wire is straightened. So we can see here fielder XT is almost close to the retrograde wire. So here I attempted to kissing wire technique to re-enter into true lumen, but that badly failed to create a complication. So as the fielder was not progressing, I changed fielder for Miracle 6, and Miracle 6 actually almost appeared like in the true lumen in a grid view, almost hugging distal corsair in this grid view. So at this juncture, so we thought of confirming wire position with the corsair injection, that is retrograde corsair injection. When I injected through corsair, this is what happened. So the contrast went subintimally, and so it created a kind of dissection here. So when I took another injection in RA view, actually the dissection got extended, and you can see there is a persistent contrast staining of this area, as well as you can see the Workhart's wire movement. This is a Workhart's wire, Renato wire, so which is just falling inside the subintimal space. So it created a huge subintimal space here. What next? So now we have an antegrade wire in subintimal space with intramural hematoma with compressed true lumen and retrograde corsair in true lumen. At this stage, so what to do? So the most important thing is we have to prevent extension of intramural hematoma in this case. So quickly occlude proximal RCA with the 3 mm balloon, which is used for base, that is balloon assisted subintimal entry. So occlude the proximal RCA, that prevents intramural hematoma extension, and then switch to reverse cart with a continuous proximal balloon occlusion. So this is very important in this case. So otherwise intramural hematoma will extend, and and we may have to terminate the procedure unsuccessfully. And if this doesn't work, reverse cart with balloon, if it doesn't work, then we can go for guideliner assisted reverse cart. So reverse cart with proximal RCA occlusion. So we occluded proximal RCA, you can see here. So proximal RCA is continuously occluded with a 3 mm balloon here. While you are sending your reverse cart balloon, briefly you can deflate and reinflate and park your reverse cart balloon here. This is 2.5 15 millimeter balloon, and then try and do reverse cart. So I tried with Gaia 3 and Gaia 2, and then I switched to pilot wire for reverse cart. So but nothing worked with the balloon assisted reverse cart, so we couldn't bring this wire back into guide. So at this stage we switched to guideliner assisted reverse cart. So while doing while replacing guideliner, we have to exchange two balloons for guideliner. So in this case, first we removed 3 mm balloon, keeping 2.5 mm balloon used for reverse cart inflated, and then get ready with your guideliner, and then deeply engage your AL catheter into the RCA so that it snugly fits into RCA, not allowing any antegrade blood flow, and then you remove 2.5 balloon and quickly you replace it with guideliner catheter. So we did that. See, 3 mm balloon is out, but still your 2.5 balloon is inflated, and when you pull guide with inflated 2.5 balloon, that snugly fits into the RCA, leading to complete pressure damping and preventing all the antegrade flow and extension of intramural hematoma. Then we exchanged with guideliner, and once the guideliner is in, we can take a 2.5 balloon and continue your reverse cart, and then we could pull pilot wire, pilot 150 into the guideliner. Then we externalized with RG wire. So once RG wire externalization is done, the first step we have to do in this case with a huge intramural hematoma is IVUS. So we did IVUS. You can see the IVUS. This is IVUS at distal bifurcation. So there is no intramural hematoma here, and you can see here this is exactly at this point. So this is the true lumen, and this is a huge intramural hematoma which is sitting in the vessel. You can see this is a huge intramural hematoma, and this is a true lumen, and this is an intramural hematoma. So you can see running frame of IVUS. So yeah, here the vessel is fine, and your IVUS catheter is in true lumen. And once I am coming proximally, we can see this is the second wire sitting in the dissection with intramural hematoma. This is all intramural hematoma. So the next step is once we located intramural hematoma extension distally. See, this is a distalmost point of intramural hematoma. So we took a stent of distal size, and we deployed it after 2 mm balloon dilatation. This is a 3 into 38 millimeter balloon. We extended beyond intramural hematoma distalmost extension, and we deployed it low pressures. Never use high pressures, otherwise this hematoma may squeeze down. And then we stunted proximal vessel with 3.5 and 38 millimeter stent. Yeah, after stunting, optimization is done with IVUS, and this is the final result. This is a first dual angiography showing RCA CTO, and this is the final RCA angiography showing So good flow into the distal RCA, and distal edge of the stent is quite good. And this is the final IVUS showing distal reference as 7.1 mm square, and these are the stent areas: 8.3 mm square, 8.7 mm square, and 10.5, and this is almost at the ostium, 10.5 mm square. So there is a good dilatation of this stent. So the learning points in this case are: calcium can spoil wire escalation strategies in a long CTO. In this case, both antegrade wire escalation and retrograde wire escalation stalled by calcium at both ends of CTO. ADR is preferred in such a situation as you can control dissection and re-entry than retrograde knuckling. So intramural hematoma spoils chances of successful re-entry if intramural hematoma is formed already. So prevention of extension of intramural hematoma is the key, which can be done with proximal balloon occlusion or deep seating guide into the vessel or equal size guide extension. ADR leading to intramural hematoma can be bailed out by reverse cart. Antegrade contrast injection is forbidden in antegrade dissection and re-entry. And IVUS is the key in deciding stenting strategy in such cases with intramural hematoma. And optimization of stenting should be done with IVUS to avoid squeezing of intramural hematoma to downstream vessel. Any increase in balloon pressure or balloon size for post-dilatation of stent should be preceded and followed by an IVUS to understand what is happening to intramural hematoma. Thank you. You can subscribe to this channel by clicking on subscribe in YouTube.